They told you it's burnout, but they lied. It's nurse trauma. Your body never lied. The system did. I'm Dr. Lorre Laws. Let's get into it. Today, I want to start with a story about a woman on a gurney. She's older, in the hallway of a hospital, not in a room, a hallway. There's a thin blanket over her legs, and it's a good one, the one somebody brought from home, because the hospital blanket, if she could get one, was too thin to warm her. There's a paper cup of water sitting on the ledge beside her, and it's gone warm. She was seen in the emergency department yesterday. She was admitted, and someone made the medical decision that she needed to be in the hospital, in a bed, getting inpatient care. And yet, there was no bed. There hadn't been one all day, and there wouldn't be one for most of the next shift either. So she stayed where she was, in the corridor, with the carts rolling past her, the overhead pages going off, people and equipment passing by, and those dreadful fluorescent lights that never, ever dim. The nurse who was in charge of her care that day, his name is Nick. He clocked in, and she was already there. Now, Nick is an emergency room nurse, and he told this story to me himself. So I'm going to try and do my best to share that right with you, because unlike some big hospitals in metropolitan areas, reporters don't usually come to the smaller hospitals or the rural hospitals. And you may have seen many strikes in the news lately. The famous hospitals, the picket lines. Nick's hospital wasn't one of those. This is an ordinary emergency department in an ordinary town. And what is happening here is happening everywhere right now, in hospitals near you, and probably in the one that you work. So before we go further, know that what happened to the woman in the hallway and what happened to Nick was not an accident. It was a design. Somebody built it that way on purpose. So let me show you how that works. There's a word for what is happening to that woman, and it's called hospital boarding, or just boarding. And boarding is not snowboarding, which would be easy for someone who's not in the health profession to maybe draw that conclusion. Boarding is when a patient has already been admitted, the decision has been made that they need an inpatient bed, and that there is not an inpatient bed for them. So they wait in the emergency department on a gurney in the hallway with a curtain, maybe or maybe not, sometimes for hours, and sometimes, and I'm not exaggerating this, sometimes the emergency physicians themselves have to testify for days. And they do testify recently to the White House that emergency department patients oftentimes are boarded in hallways for days. Now, notice the word boarding. It's bureaucratic on purpose. It sounds like something that happens to your luggage at an airport. It's supposed to sound like a logistics term, something small and procedural that doesn't really paint the picture of exactly what it is, which is a sick human being parked in a corridor of a hospital because the room, the bed that they need is full. And you might be asking the obvious question, why is the room full? This is where it stops being an accident or an inconvenience and it starts being a system design. Hospitals run their beds full the way airlines oversell their flights on purpose, because an empty staffed bed loses money. A physician who runs an emergency department at Johns Hopkins recently said this to a reporter. He said that hospitals today run like airlines, that they intentionally overbook and they keep fewer beds than they used to, because an empty bed with a nurse assigned to it is a bed that costs the institution money and earns nothing. So that bed stays full. And which patients get the rooms, do you suppose? Well, spoiler alert, it's the profitable one. The elective surgery, They get the beds. And the woman who is in Nick's emergency room, she's waiting in the gurney in the hallway. Now, stay with me because it gets worse. And it gets worse in a very specific kind of way. The accreditation body that governs Nick's hospital is the Joint Commission. And the Joint Commission has a standard. It says that a boarded patient must receive the same level of care that they would had they gotten a bed upstairs, the one they were waiting for. The same care. So the same care as if the patient was upstairs on the unit in a bed with a real room and a dedicated nurse and a full care team. The Joint Commission even recommends that boarding not go past 4 hours. But here's what they never did, because they never do it. They never enforce it. They never put teeth in it that have consequences for the hospital. They never make the 4 hours a requirement. That number just sits in a document somewhere while a patient is literally down the hallway in a gurney, way past 4 hours, past hour 20 and into the next day. So think about the position that puts our nurse Nick into. There's the standard written down, binding, says to give her full inpatient care, and that's his intention, and yet that's not how the unit is staffed, which makes that standard of care flat out impossible. And then there's Nick standing in the gap between the two. Like so many nurses, that chasm of how we're supposed to deliver patient care and how the system handicaps us from doing so. He couldn't even have told you that afternoon whose patient she officially was, not because the assignment didn't exist on paper somewhere, but because the department had gone so far past capacity that the question didn't even have a clean answer anymore. The waiting room was overflowing. Every bay, every room in the ED was full. Both corridors were lined up with gurneys, and the ambulances kept coming. The new emergencies, they kept happening. So Nick is moving and triaging as fast as he actively can. People are crashing while others are silently suffering, like this woman in the gurney. She was in the second group, suffering quietly in a hallway, on a gurney, in a public space, waiting for a bed. And the ones who suffer quietly and don't make noise, they're often the ones that get overlooked. This patient needed help being turned. She needed some water. She needed someone to notice her hours earlier that her condition had changed. She was starting to decline. What she had instead was one nurse running from room to room, doing their very best, physically impossible to attend to the sheer number of patients, all needing attention at the same time. This is an egregiously understaffed unit, and leadership is carrying full knowledge of that. That's the machine. A sick woman has been reduced to a boarding pass. A skilled nurse reduced to lost luggage. Both of them fed through a system that decided a full bed was worth far more than a safe one. So if you're listening to this, it's probably landing. You've probably seen this happen, or you know of someone to whom it has happened. And so this is where we can take the reins and get our power back. There's a free assessment on my website at drlorrelaws.com/assessment. It takes less than 2 minutes, and it will help nurses like you and like Nick to stay safe and regulated in our nervous systems, even when it's a dumpster fire working conditions like what we're describing here. So take a look and see where you are being affected by nurse-specific trauma, and I'll send you a full report. Now, let me get back to what happened to Nick. As Nick and I were emailing back and forth, he took that assessment, and it told him something that he had not even let himself see. He was carrying so much more than just quote-unquote burnout. He had the exhaustion that sleep doesn't touch, the aches and pains that were unspecified and didn't have a real origin. No one could explain them. The brain fog, the pulling away from the people that he loved, those strange moments of watching himself from somewhere outside of himself. And underneath all of it was hopelessness. He wanted out, and he didn't know what to do because everything that he had tried had failed, and he ended up right back where he started. One of the millions of nurses who are, by the way, the sickest of all health professionals, and Nick is among them, and you may be as well. Now, sure, and like any good organization that's going to shellac over the real root cause, which is nurse-specific trauma, they're going to dress it up and call it burnout. There were burnout posters in the break room. There are burnout posters in the restroom. And I want to be careful here because the people who put these posters up, they mostly mean well. They're executing orders from leadership in the C-suite. But well-meaning doesn't get to root cause. And burnout is not the root cause. Burnout is a symptom cluster. And it's what nurse-specific trauma looks like on the surface. Think about what the word burnout actually claims. Burnout says Nick was tired and needed a vacation. Burnout says that Nick needed to do more self-care. Burnout says that the problem is inside of Nick. It's his attitude, it's his resilience, it's his failure, it's his deficiency. Burnout says if he'd just rest and change, well, he'd be fine. Well, and that's the story that the healthcare system and the wellness industry has been selling nurses for over 50 years. And it's a lie, and a very profitable one, I might add, because it places the blame and the injury inside the nurse instead of the institution that caused it. Now, what Nick is carrying is not exhaustion, it's nurse-specific trauma, and it has a shape, and the shape has names. There's different kinds of trauma, and the primary one that is being affected here in this scenario of Nick is insufficient resource trauma. This is the injury of being unable to give the care that your training and license legally obligates you to do. Dr. Karen Foley is a nurse scientist, and her research, along with mine on nurse trauma, calls it exactly that, insufficient resource trauma. It's not a metaphor. It's a documented scientific category. And then there's second victim trauma. This is what happens when you watch a patient move toward a near miss or an adverse event, or heaven forbid, a sentinel event, because the system hamstringed you, handicapped you with insufficient resources to do your job. And despite your best efforts, an adverse outcome resulted, not because you failed, but because the system design failed and made you responsible for their shortcoming. Those are two of the 7 types of nurse-specific trauma, and Nick was living inside both of them in one shift. And this was also happening to the patient, was experiencing system-induced trauma. So now let me show you what the system did about all this, because the system knows that this boarding practice happens. It's known for more than 40 years. This past November, after 4 decades, the federal government finally acted. Medicare finalized a new rule that adds a measure of emergency department holding. And this rule is really a masterclass in smoke and mirrors, like so many things are in healthcare. Hospitals will now have to report how long their patients are boarded for. That's it. They just have to report it. Just let us know. That's it. And until the end of 2027, that reporting is voluntary. It'll become required in 2028. And ultimately, it will be tied to payment in 2030, but not in the ways that you might think. It's going to be in the form of a data collection fine. It's essentially a form that has no teeth, no real penalty, other than an administrative slap on the hand for boarding a patient in a hallway for 30 hours. The only financial consequence in the entire thing is a small reduction for the hospital that fails to turn its paperwork in on time. No consequences to the trauma being inflicted upon that patient. No consequences for the trauma being inflicted upon that nurse. I really had to sit with that for a minute. A fine for being late on a form. That's it. It's almost hard to believe that a hospital can board patient for days and pay nothing as long as it submits its form on time. And only if it forgets to report might something be done about it in a timely manner. So here's the part that tells you where the urgency really lives. That same rule, that same document, raised hospital outpatient payments, cleared hundreds of procedures to move faster, outpatient and surgery centers, and streamlined the profitable elective throughput. The exact throughput that keeps the beds full in the first place. So here we are, one rule. In one rule, the elective surgeries get speed and money this year, and the boarded patient, like the one in Nick's care, gets a hallway measured in a form that doesn't have to be submitted until 2030. The system found the will to move fast on what earns money, and it almost never touches the harm it inflicts. That's not a broken system. That's a system that is doing exactly what it's designed to do. It's succeeding in being profitable, and that's the whole point. So let me talk to you now about Nick and about you. If you're a nurse, you probably have already seen this hallway. You've probably been Nick, or maybe you were Nick even this week. You've been the one moving between the patient who's crashing and the patient who's going downhill, the patient who's swirling, the one that's in the hallway, and everybody needs everything all at once. And no human being, no nurse can respond to that many patients in these conditions. And having to decide in real time who needs to receive treatment first and who can be deferred when everyone needs it now and no one should be deferred. That's the crisis. That's the trauma. That is the insufficient resource trauma. And so if you've carried any of this with you home, if you've had the nightmares, if you feel the dread before your shift or the weight on your chest before you go back in, or if you've sat in the parking lot before or after your shift wanting to scream and cry, or if you've sat in the parking lot before or after a shift and wanted to scream or cry or both, or even maybe punch the dashboard, you couldn't do either. So you just sat there and your body is holding that trauma. It will hold that trauma until conditions are favorable for healing. And that's what I'm here for. That's what this scientific work I'm doing, the research I'm conducting, and the nonprofit and the programs I have for nurses, that's what we're addressing. No, we all know that being handed a cold slice of pizza and putting a healthcare hero poster in the break room is gaslighting, and it's empathy manipulation. They told us to set better boundaries. They tell us to have a gratitude practice, and then they tell us that we're burned out. You were never burned out. You were injured by a system that decided a full bed was worth more than a safe one, and then handed you the bill of the trauma to carry that caused it, not only for you, but for your patient. And then it spills over into everyone's home. So now everyone is suffering as a result of the system issues. So the moment you stop calling it burnout, that's the point of power, or the point of empowerment, as I say. And that's not a small thing. It's also not the end of the story. That's where the process of recovery and reclaiming our health and safety and professional well-being from the system that stole it. That's the point of empowerment. The recognition is the first real step, and now you know. The 4 forces I've been talking to you about over the past several weeks were all alive and well today in that one hallway. The manufactured staffing crisis. We have enough nurses. We don't have enough nurses that are willing to be traumatized avoidably in their roles. Nurses are stretched past capacity. Nurses are ending up, and currently are, the sickest of all health professionals. And the suffering that spills over to the patient's family, to your family, that is real. Nick is suffering. The patient is suffering. Both of their families are suffering along with them. So recognition is the first thing, and next week I'm going to show you what your body actually does with that recognition. When awareness isn't the finish line, it's really the first step out of the gate. So if you have a story like Nick's, I would truly love to hear it. You can reach me on any social media outlet, or you can share your story anonymously at drlorrelaws.com/contact. I read and respond to every message myself. You just put a dash in where the name field is, and we do need your email address, of course, to have a conversation, but I don't need your name. So that's a wrap for this week. Be sure you head over to drlorrelaws.com/assessment, take your free nurse trauma assessment, and I will send you a free report with guidance for your next step. Your body never lied. The system did. From my healer's heart to yours, and until next time, namaste.